Hi, friends. Um, hey, quick question. Does anybody know where we left off? I think it was somewhere in digestive. Just the four of us today? What, are people skipping out or something? How dare they? About 5 people. All right, we'll give it another minute. Maybe some stragglers or stragglers will come in. All right. Clear. All right, we'll get started. Um, did we stop at the small intestine? Did we go through the stomach? Anybody know? Let me see. No, no, not right now. Go.
We stopped at the stomach. We did it and then stopped.
Did it and then stopped. Okay. Small and large intestine. All right, we'll do that then. All right, speaks for everybody. Okay,
Per usual.
per usual. Okay. Let's keep going then. So, the small intestine. Okay. Sorry, I had to go through a whole bunch of lectures today, so I wasn't like I was like, where did I stop and start? And I don't know. Um, stomach, small intestine. Okay, from curves. All right, Let's talk intestinal system. Okay. All right. So let's go back to the stomach real quick. So from here, we've got the stomach. Food is kind in the stomach, right? It gets mixed up and jumbled about, right, and broken down. Okay, so there's a lot of mechanical breakdown here, and then it goes into here in the pylorus, which is this last portion of the stomach, and then through the pyloric sphincter. Okay, so there's a valve here that allows food to go through. Okay, anytime you think of sphincter, um, you can think of your eyes; those are a sphincter. You also have an external anal sphincter. That's all the internal ones look like the external ones. So use your imagination. So it goes through the pyloric sphincter and then into the small intestine. Okay, so from there, we're gonna start from there. Okay, so that food goes into the small intestine. All right, we've got three portions of the small intestine. Okay, so we've got duodenum or duodenum, depending on who you are. There's the jejunum, which is this next section, and then the ileum, which is this part right here. Okay, and these three segmentations, I guess you could call them, do different things. Okay, and that's what kind of differentiates between them. If you were to like stretch the whole small intestine out in like a big long row, a big long rope, you wouldn't really be able to tell, like other than like, well, the duodenum is the most proximal one, and the you know ileum is the most distal one, right? So you wouldn't really be able to tell like what's what. Um, they're like on a smaller level, like yeah, like if you really focused on it for a while, you'd probably figure it out. Um, but and then there's like other little things that kind of go on, like for instance, like Peyer's patches. We talked about Peyer's patches from lymphatics, and those exist within the ileum, but not anywhere else, right? So like the terminal ileum is where you can find those Peyer's patches. So like over here. Um, so like there's little things that you can find that differentiate between these three sections. But for all of like for the purposes of this class, they're all small intestine. Okay, so if I say like a test question might be, which of these is not a portion of the small intestine? Duodenum, jejunum, ileum, rectum. Like not the rectum. Okay, it's just these three. All right. The duodenum. Are we going? Oh, okay. I'm not looking at that. All right. I'll just keep breaking it down. But just kidding. So the duodenum is this first like 10 centimeters of small intestine. So there's very specific things that happen there. There's a couple spots right here. Like there's one little opening here and one over here, where we see accessory organs doing things, and that happens in the duodenum. The jejunum, you don't really get a lot of that, and then the ileum, you have like more specific absorptive things happening in the ileum. So that's the difference between those. So if you were to take like a pile of intestines, right, and you were to say, where's the duodenum, where's the jejunum, where's the ileum, you could pretty much go, okay, from here, the first 10 centimeters is duodenum, and then like give yourself another 5-10 centimeters, and you could probably like fairly accurately say like this is jejunum. And then if you go all the way to the other end and you work yourself backwards, you could say, okay, this one's definitely ileum. So as far as like what the jejunum and ileum do, it's absorptive stuff. So we'll go over this a little more when it comes to metabolism, and then accessory organs as well. We'll kind of dive into these a little more. But they all do have the relatively same histology. Okay, so we see within it, within the lumen of the small intestine, we see these villi, right? And then microvilli and like these circular folds. So it's almost like you take a tube and then you squish it, and then it creates these little wrinkles on the inside. And that's what's happening basically. And the purpose of that is increase surface area. Just like everything else when it comes to histology in the whole body, we want to increase the surface area. And so the more surface area we can get out of our body, the more efficient it'll become, right? So we have these wrinkles that we call villi, and then if you kind of zoom in on a villi, you have these little microvilli, and these microvilli, these create what's called the brush border. Okay, so that's an important term, the brush border, right? And that's just this section right here. And then you have crits where some absorptive things happen. And then you have absorptive cells. So like each individual cell, like this individual cell, um, will absorb nutrients that way. So we're not really breaking down nutrients anymore. We kind of are, but we're more absorbing the nutrients that are already broken down. Okay. So we've gone through that whole metabolic process of taking a steak and breaking it down to individual proteins and then breaking that protein down into individual amino acids. And we're now absorbing those amino acids, okay, or fats or starches, whatever. Let's see. This is kind of what it looks like on histology. So you can see it's fairly accurate. Like you look at it and you're like, oh, okay, that makes sense. This has got to be a microgram. It is a microgram. This is super zoomed in. And this is just right here. This is just this brush border, this little square right here. So each individual cell has these little tentacles that kind of go like this. And it's freaky to think about that there's something in your body going like this. There's a lot of things going like that in your body. Just so you know. All right. Don't miss anything. This right here, this green, is lymphatic vesicles, lymphatic vessel right here. And it has these little things sticking out, these little pokey things. And those are called lacteals. So there's a specific name for those. So lacteals, and then you also have arteries and veins as well. So the things that you're absorbing get absorbed. They drain into the lymphatic ducts or lacteals, and then the veins as well. And all of this is supplied by the arteries. Any questions? That's it for that. All right, so there's 3 phases of gastric secretion. So you have the cephalic, the gastric, and intestinal phases. And during those phases, you can inhibit or secrete or stimulate secretion of different gastric juices. Okay, juices probably they're probably like chemicals or enzymes would be a better word. I don't know why it says juices, but so during the cephalic phase, this is just cephala. It's a head phase. So this is just I'm thinking about food, or I smell some food and it smells really good, or I ate too much food. Okay, these are uh, these are based off of hormones. Okay, so if you see food, you have a hormone secreted by the cerebral cortex, and it conditions a reflex in the hypothalamus and medulla oblongata, which stimulates the vagus nerve and stimulates stomach secretory activity. Okay, vagus nerve. What is it? Hang on. It is. I'm going to show you Wikipedia because it does a lot of stuff. This is the vagus nerve. We've heard of it before. So it looks like this. It's got a lot of stuff going on, and it goes all the way down into your stomach. Okay. And it starts in your head and it works all the way down. It's called the vagus nerve because, like vagabond, it's the same root. So it does a lot of different things. So it like acts on your heart, it acts on this other stuff, and it works, and it's a cranial nerve. Okay, it is a parasympathetic response. So it's part of the autonomic nervous system, and that is important because it is not something you can control, right? So this all happens. This is a reflex. Okay, this happens within your body. There's nothing you can do to like see food and then be like, I want to secrete secretory stomach enzymes. No, that doesn't happen. It's just a reflex within your body. Okay. Same thing over here. Loss of appetite, depression, stimulates your cerebral cortex, which will pull the gas off the parasympathetic centers of the vagus nerve and it will inhibit stomach secretory activity. So it's not stimulate the vagus nerve, stimulate some other nerve. It's stimulate the vagus nerve, back it off, and it will inhibit that process. Okay. So it is a negative feedback loop right here. Okay. All right. So during the gastric phase, so say you've eaten some food. Okay. So stomach distension activates stretch receptors. So we've got receptors within our body, right? And you'll have vasovagal reflexes. So blood flow. That will. Let's see if I can show you a picture. Pull back. Let me pull back to the PDF. I think that was a good picture. Central nervous system. We'll just do this. See if I can find a good picture. Let's use this one. All right, so let's say this is the stomach right here. Okay, I don't know if it's but we'll just pretend for this purposes. Okay, so your distension will activate a reflex that will go back to your spinal cord. It'll travel up to your medulla, and then it will come back down the vagus nerve. Okay, and it will stimulate secretory activity. So you're secreting hormones that are being secreted in anticipation of breaking down food. Okay, so those are the same hormones as here, right? So this is kind of the same mechanism, right? And then you also have food chemicals, and rising pH activates chemoreceptors. So those hormones get secreted into the blood, right? So it's not a nerve response, it's a hormonal response. And those are caused by G cells, which secrete gastrin. So G cells, gastric phase, gastrin. Gastrin is a hormone, okay? And when it gets upregulated by the brain, it stimulates stomach secretory activity as well. Okay, so where we've got a nervous response and we've also got a hormonal response. Both of those are telling the brain, hey, produce more stomach acid and more, like secrete more stuff. Okay, now that can be inhibited by excessive acidity in the stomach. So we've broken down everything, and now what's left over is just stomach acid, right? And a whole bunch of floating stuff dissolved in the stomach acid. And that gastrin secretion will decline. Okay, so think if you are, if this secretion mechanism only works within a pH of 4 to 2, and then it drops below 2, then it won't create that mechanism. Okay, so like you're gonna break down the enzymes that stimulate that mechanism, and then it'll stop happening, right? That makes sense. And then the other thing you can have is emotional distress, right? So like if you are eating a sandwich, somebody stands up and they're like, hey, I'm gonna punch you in the face. Then you'll freak out and have a fight or flight response. And that is a sympathetic nervous system activation, which will override the parasympathetic control. So if the vagus nerve, parasympathetic, is stimulating stomach activity, a release of epinephrine into the system will trigger a flight or fight response, which will it will back the foot off the pedal of the parasympathetic controls. Okay, so fight or flight, rest or digest. If fight or flight's happening, your body says, hey, it's not that important that I eat this right now, let's run away. Kind of the same reason why, like if you um, like scare the crap out of somebody, that you scare somebody so bad that their body is just not digesting. It's like release, we're done. So that's what's happening there. Okay, that's a bad example. I mean, but it's a true example. You can't scare the crap out of somebody. Okay, so that'll inhibit secretory activity. Okay, it tells your body, stop. We don't need this right now. Okay. And then there's the intestinal phase. So the food has moved from the stomach and into the duodenum, and you have to tell your stomach, hey, there's nothing there. You don't have to secrete anything. You don't have to break anything down. Okay. So there's local reflexes with nervous system activation. There is stretch receptors in your duodenum, and your pyloric sphincter is close to your duodenum. We just talked about that. And you'll have an enterogastric reflex, so that's another nervous response. And then the vagal nuclei and the medulla will also inhibit the secretory activity. Okay. The distension and presence of fatty acidic or partially digested food that will also release intestinal hormones as well. So secretin, gastric and peptide, CSK, vasoactive intestinal. So all of these hormones that are released will inhibit stomach secretory activity as well. Okay, so negative feedback loop. Okay. All right. Any questions? It's kind of hormonal. It's kind of neuronal. There's a lot of responses that happen in your body. A lot of them are redundant. And the big thing to take away from that is that we are either eating or we're not eating. So we either need our stomach to work or we don't need our stomach to work. Okay. All right. Segmentation. So, and this is a good picture. I like this picture. So segmentation happens in the small intestine. So we have these little bumps, right? And we know we have peristalsis that moves them through. So what that does is it will kind of like naturally create little pellets, right? Think of like a rabbit where it just creates these little poop pellets. You kind of do the same thing a little bit. And then it kind of gets all squished together at the end. So that happens within the small intestine. And basically, you're taking that whole ball of chyme right here, you're cutting it into two subsections. You're cutting those, and they're mixing together during peristalsis. And then you just kind of keep doing that over and over again until you end up with this homogeneous mixture, basically. Okay, and that provides time for digestive and absorption. And it also helps move, like, as you absorb nutrients from the outside of this little rabbit pellet, you need to squeeze that rabbit pellet to the next segment, right? So, like, you need to move all the nutrients that are on the inside to the outside because they got to be absorbed as well. So, this segmentation, what it does is it helps, like, kind of mix it up and create homogeny within the mixture so that you're absorbing at a slower and more controlled rate. Okay. All right. Any questions on the small intestine before we move on? Pretty straightforward. It's absorption. We're going to learn a lot more about it in metabolism. There's a lot more stuff that goes on in here. And we're going to deep dive into that. And if you're lucky, you'll go on and take a metabolism class and you'll have to learn all kinds of mechanisms. It's super fun. I hate it. But I have a good book if you need a recommendation. All right, so food goes from here into the large intestine. Okay, so from here it goes into the large intestine, also known as the colon, and then it goes through all these sections. Okay, this bottom section is the cecum. So you have your terminal ileum right here, and then you have your ileocecal valve, right? There's a sphincter right there as well. So there's an ileocecal valve that the food gets pushed into that, through that, and into the cecum. Okay. Your appendix. Anybody want to guess at what an appendix is? What's it for? Nobody knows? That's good. It's largely vestigial, which means it's left over from evolution, and it doesn't really do anything now. It has poison. It does not have poison. It can get infected, which is bad. When it gets infected, it will blow up, and that's bad. So it's the infection that's the poison. It's your own body that's infecting that, right? Because we learned about infectious inflammatory responses. So there's bacteria that's growing in here, growing and growing and growing. And then it swells because you have an inflammatory response. So you have an inflamed appendix, and then it gets too big because it's real tiny, and then it blows up. It does blow up, and that's bad. Did you know you actually don't need to have an appendectomy in those situations? And America is one of the very few countries in the world that routinely provides an appendectomy for people in those situations. The whole rest of the world gets antibiotics and they call it a day. And there we go. Ding, ding, ding. That's why. I actually had a friend who was in the Navy. He wasn't a doctor. He was a medic in the Navy, but he was on submarines. And when you're the medic on the submarine, they call you doctor because you're like 4 days away from a doctor at that point. So he would have people that would get appendicitis, and he would give them antibiotics, and it would cure them, and they never had to worry about it. So you don't actually need a surgery. The only time you really need a surgery is if it does burst, and then you definitely need surgery because they have to clean all that crap out, literally. Another thing I want to tell you about the appendix. Hang on, I have to Google stuff. It can exist. This is a fun fact. It can exist in all of these different spaces. So it can be pelvic, which is normal, like what we would consider like a normal appendix. It can be subcecal, so behind the cecum. It can be retrocecal, so completely behind the cecum. It can be post-ileal, this way, or pre-ileal. And all of these are normal anatomical variations. And they occur, hang on, I'm going to give you the frequencies because I bought the book and I read it earlier. Frequency chart. Give me a frequency chart. Here we go. This is from sonoguide.com, which is a very legitimate resource. Okay. They are pelvic in 32% of people. They are retrocecal in 64% of people. 64% of people, you can't even really see it on a CT. Okay. Post-ileal in 0.5% of people, pre-ileal in 1%, and subcecal in 2%. So mostly retrocecal, sometimes pelvic, and sometimes other stuff. So that's a fun fact. And all of those are normal. Retrocecal appendix is really hard to see on a CT unless it's inflamed. Okay. So when you go to the ER because your tummy hurts and you think you have appendicitis, they may or may not be able to see it. And a lot of times it's a clinical diagnosis. So they're going to go, touch. Yep, that hurt. Cool. You have appendicitis. Going to the OR. So that is a true fact. All right. So that's the appendix. all of that for a relatively unimportant part of the large intestine. I have less to say about the rest of the intestine. Okay, so we've got the appendix, we've got the cecum. The colon is broken down into three parts. Okay, so there's the ascending, sorry, four parts. There's the ascending colon, there's the transverse colon, and the descending colon, and then the sigmoid colon right here. Okay, and these are differentiated by what's called flexures. So the ascending colon will kind of go into a point, right? And then there's a ligament over here that kind of tacks it to the peritoneum. And then from there, you've got transverse, which is connected by another ligament over here at the left colic flexure or the splenic flexure. So there's the hepatic because the liver is right here, remember anatomy. And then you've got the spleen over here. So this is called the splenic flexure or the left colic flexure. On the superior side of the colon, it's attached by the lesser omentum to the stomach right here. So the greater curvature of the stomach will be right here, and it will attach to the colon. Let me see if I can show you a picture of that actually. It's kind of neat. Colon. Let's see. It's a very fun dissection. That's the uterus. That's for okay, so let's start here. All right, so if you've got a cadaver right here, this is the omental apron. So this is the greater omentum. Okay, and then you're gonna flip that up, and you'll see the colon. Okay, so let's flip it up. Let's see the colon. So we've got the transverse colon right here, and it looks like ascending. This is the whole colon is flipped up a little bit. So this transverse colon is connected to the stomach up here, and then it descends over there. Let's see. No, but this is what your small intestine looks like. That's the circular folds. That's really neat. I like that. It's cool. Here's the cecum right there. What is the appendix? Retrocecal, probably. All right, and then we've got the transverse colon right here. So you can see it's right there, and then this is the stomach. Okay, so it's like you can kind of see it's attached right there. This one a little bit, you can see it's attached. Ooh, this is nice. That's a super fun dissection, actually. This is all the vasculature in the portal system. This is cool. No, it's all reflected. But this bottom part right here, this is where it's just attached to the stomach. So there is a little bit of this like lesser omentum stuff. The mesentery is attached. Cool. There's some really cool blue leaf stuff. You guys are gonna be loving lab for this section. There's a lot of cool stuff. So yeah, that's the colon. And then we have the sigmoid colon at the end, and then the rectum and the anal canal. Okay. So you've got an internal anal sphincter, and then just like here, and then an external anal sphincter right here. So between here and here, there's no sphincters. So there's not a sphincter between the rectum and the colon. It's just a change in the differentiation of cells. Okay, so there's a junction. Those contract, right? What's your sphincters? Hopefully. I really hope so. Otherwise, change bridges. They are naturally contracted, all right, and you can uncontract them. but they're held closed at all times. Normally, hopefully. Where did I go? Jeez. Okay. Histology. All right, let's look at kind of what it looks like on a cellular level. So if we kind of zoom in, you can see that it's a little different. It still's got some folds, but and it still has microvilli, but it doesn't really have those like the circular folds like the small intestine does. Okay. We've got glands, we've got lymphatic nodules, like lymph nodes in here. We've also got goblet cells, which secrete mucus. Did you know there's mucus in your stool? I did, and it's kind of gross to think about, but it's all very normal. And then we're also absorbing water this way. So if we pull the water out, we're going to put a little bit of mucus back in, and then it's going to help move things along. Okay. In a normal person. In an abnormal situation, it will harden and it will become a blockage. That's not good. So it's a little more simplified here. We still have those microvilli, but as far as the large intestine goes, it's absorbing water. It's mostly what it's doing. Okay, so there's some other little functions, but for the most part, it's water reabsorption. Or if there's too much water, it's pushing water out. Okay. All right. So there's a couple things when you zoom in on a large intestine that exist that don't exist on the small intestine. So we've got these big bulges, okay, called haustra. And let's see if I can give you a. I should have kept that blue link open. Let's see. All right, let's look at the intestine. All right. All right, so we've got these like weird bumpy things, okay? You can see them like here. This is just in the colon, okay? You see the small intestine, it's smoother and a little more wrinkly. But this is like bulgy, okay? It's like a weird balloon. And those little bulges are called haustrums, okay? So that's a haustrum of the colon. And then you also have, there. Right. You also have these little like fat dangly down things right here. Those are omental appendages or epiploic appendages. So those are what that is. And then you've also got this line on your colon, okay, all the way around it. Let's see if I go back and you can see it. All right, this little flat line right here, it's straight, okay, and it goes all the way through. That is called the tenea colon, right? All right, and those are just little anatomical terms, but these are specific to the colon or the large intestine, and they don't exist on the small intestine. Okay. Okay. Large intestine questions. Any questions? So if I show you a histology slide in a lab test, and I say this is a part of the intestine, which part is it? What would you say? You would say large intestine because the small intestine is more gappy. Okay, it's got these bigger surface area things, and you got to get food down between these, right? Like you've got to get broken down nutrients into there. Whereas here, you are just reabsorbing water mostly. Small is more gaps. Yes, smaller is gappier. The small intestine is gappier. You gotta squeeze the food into those spaces. You don't have to squeeze the food into the spaces to absorb the nutrients. It's mostly water reabsorption. So the gaps are smaller. So Couple confusing things about the intestine. The small intestine is longer and it has bigger gaps. Both of those things make you think that it's not the small intestine. The large intestine is shorter and it has smaller gaps. Okay. The reason we call it a small intestine versus a large intestine is diameter. Okay. Not length or anything else. Just straight up internal diameter of the lumen. So, which is why a lot of times you don't even call them the small and large intestine. You call it the specific intestinal section. So you would call it the duodenum or the ileum, or you would just call it the colon. Okay. And then like within colon, you go ascending, transverse, descending. Okay. All right. That's it for colon. Accessory organs. So if everything up to this point is the digestive system, what do we keep talking about? There's other stuff working on it, right? These are called accessory organs. So these are digestive organs, but they're not considered uh, part of the digestive system, right? Because they're not within the digestive tract, but they do secrete things. They do secrete enzymes. They do affect the rest of what the digestive system is doing. And they do a lot of other stuff that's super important. Okay. So those organs are salivary glands. So up here, the liver, the gallbladder, and the pancreas. And not the spleen, but that's here for some reason. Okay. All right, let's talk about salivary glands. You've got submandibular salivary glands. You've got sublingual salivary glands. Those are here. And then you've got a parotid salivary gland. Okay. Each of these have ducts. So you've got a parotid duct. That's a fun dissection, by the way. The parotid gland through the duct and into the mouth. That's super fun. You've got a submandibular duct. And actually, if you start like getting really hungry and like really salivating, you can kind of take your tongue. You can find where it's like pumping out saliva from. So it's like on either side on the inside of your teeth, right down there. So dig around and look weird and see if you can find. You won't find like the hole, but you'll feel like, oh, this is where that duct is coming out of. Okay, so you can totally do that. Or you can just look weird and do it. Okay. And then you also have a sublingual salivary gland that's under your tongue. So there is like a little duct there, but it's mostly just secondary. Okay. And there's like a whole bunch of them there. It's not like one duct. The parotid duct is one duct, which is cool. All right. Let's talk about the liver. Okay. So this is a liver. Okay. The liver is divided into lobes. Okay. In each lobe, they don't really do anything different. Like each lobe doesn't do anything different. It's all liver tissue. But they all are, your liver is subdivided into these subunits. Okay. So if this is like a central vein, from there, you're going to kind of branch out into sinusoids, which are like small sinusoids, right? And then you've got ducts that are running through, the bile ducts that are running through, and then you've got portal venules, portal arterioles, and you've also got hepatocytes that are kind of filtered throughout. So all of this looks like very complicated, but this is really what it looks like. Okay, so like if you were to take a section of the liver, you would see these like really highly organized subunits called globules. And from there, you would see like all of the, like if you were zooming more, you would see really, really structured, organized lobules. Okay. So it receives oxygenated blood from the hepatic artery and nutrient-rich deoxygenated blood from the hepatic portal vein. So all of the food that you digest drains into the hepatic portal system, into the hepatic vein, the portal vein, and then from there it goes into the liver, and then from there it drains into the vena cava. So eventually, so you have these interlobular veins to the hepatic vein, and then from the hepatic vein it goes into the vena cava. Okay, so this right here is your vena cava. It's the least oxygenated blood in your whole body, almost. And it's the most dense, nutrient rich blood in your body. So you are picking up nutrients in the most oxygen poor environment in your body in the vena cava. Okay. So when it goes to the heart, you're not just delivering oxygen from the lungs, you're also delivering nutrients from the liver. Okay. And the nutrients don't come from the liver, but they are filtered through the liver. Okay. The gallbladder, and I think that's all we need to know as far as anatomy, but we'll probably dig into this more in lab, okay? Because it's not much more complicated than that, but there's more to it, okay? Your liver has lobes. So you've got the right lobe right here, it's really big. And then you've got the quadrate lobe, which is like kind of this bottom, not the gallbladder, but like behind the gallbladder. And then you've got the left lobe and the caudate lobe. There's like a little dangly lobe on the bottom side of your liver. Okay. So those are the four anatomical lobes. There's also 13 surgical lobes. There's 13. There are, yes, I know there's four anatomical lobes. And there are. I'm going to show you. There we go. Maybe there's an 8. I think there's an 8. So you can divide the liver into these surgical lobes. This is the surgical lobe. There's 8. So you can see you've got the portal vein. It branches off to each of these lobes of the liver. Okay. The reason they're surgical lobes is because they have different blood supplies. So there's 8 different blood supplies to the liver. Okay. So you can isolate all of these surgically. So your portal vein goes in, it brings the blood in, it gets filtered by the liver, and then it drains into the hepatic vein, which drains into the IBC. Okay, so that's kind of the flow of all of that. So the artery is providing oxygenated blood to your hepatocytes so that they can do their job. And then the veins within the liver bring it back to the IBC eventually. Okay. So this is a good representation of what like the vasculature in the liver looks like. Okay. So please. All right. So liver. All right, and then we have the gallbladder. Okay, the gallbladder is not like wildly important. Okay, um, it doesn't create bile; it stores and it concentrates bile. Okay, so bile is created in here by these little hepatocytes, and then they drain into the bile ducts. So you can see they kind of drain into here, into here, and then from there, all of those drain into the right and left hepatic duct, into the cystic duct, and then from there they go up into, into the cystic duct, and then into the gallbladder. Okay, so the gallbladder has a body, okay, and then it has a fundus, just like the stomach has a fundus. It's got a little bulgy part. It's a fundus, and then it's got a neck. So there's a neck right here. Okay. And then when you need the bile, okay, so you're either creating and storing it up or you're pumping it out. This is a parasympathetic nervous response as well. So this is stimulated by a parasympathetic nerve, and then it just squeezes. Okay, so it squeezes all that stuff down back through the cystic duct and into the common bile duct. And then from there, it enters the digestive system. Okay, so that's the gallbladder. Gallstones are super concentrated bile. Those are bad because they get stuck. You can see how this is like cavernous. They can get like lodged in here, and then you can't do anything with that. And then it's not poison, but it does create an inflammatory response. This can cause an infection, and then this whole thing can be infected, and they do have to take that out. I don't know if you can take antibiotics for that. I think because it's a stone, I think they have to remove the whole thing. Somebody asked, is it bad if you take the gallbladder out? Kind of, but you can live without it, right? Because you're just not going to have very concentrated bile, and it's not going to be stored for when you need it. It'll just be kind of leaking down into the digestive system. So you're not going, because it's not concentrated like that, you're not going to be able to break down fats as well. So you'll have a little bit of trouble digesting fats, but other than that, it's not like a huge deal. So, and then your body will also compensate for that too eventually. So if you get your gallbladder out at like 25, by the time you're like 60, you won't even notice. Hopefully. Don't do keto if you don't have a big gallbladder. Yeah, exactly. Try 16. What's 16? Is that a fat diet as well?
I got mine out at 16.
Oh, at 16? Yeah. Yeah. So hopefully in the next like 40 years, you're just gonna be like, yeah, whatever. Also, the other thing about that is like you're gonna change your eating habits. So you won't really even notice, like, because early on you might have noticed like, oh, I ate a hamburger and it hurts. And then like later on down the line, you just be like, I just don't even want to eat that stuff. So not a big deal. It can be like super debilitating to have cholecystitis, but you'll live, I think. Prognosis is good for people who get their gallbladders taken out. They generally survive. Okay. Chemical digestion. A closer look. Any questions about the gallbladder or the liver before we move on? Nope. Great. 8. Don't do keto if you have a gallbladder. Also, just general point of conversation, don't do fat diets at all. Just have a nice balanced diet and you don't have to worry about any of that. Have your macros. Okay, digestion and absorption. That's what I learned in metabolism. I took 2 semesters of metabolism to learn, like, hey, just have a balanced diet, you'll live. Go figure. All right, digestion and absorption. So we digest things through a couple different means, and then it gets absorbed mostly in the small intestine, and then, like we said, water reabsorption happens in the colon. Okay, so up here we've got mechanical digestion, including chewing and swallowing. So when you're nomming on that food, you're breaking it down manually, right? So you're taking a knife to the meat and you're breaking it up. Or you're taking the garlic and pushing through the garlic press, manual digestion, okay? Chemical digestion of carbs and fats. So from there, you've taken your meat, you've pounded it out, and you've cut it up into little pieces. You squeeze a lime on it, okay? That's going to start digesting it chemically, right? It's acidic. So you're going to start digesting up in the mouth. You have chemical digestion of carbs and fats. that is done through saliva, right? So you're taking your meat and you're throwing it in a bucket of lime juice and you're soaking it in there. Okay, so mechanical and chemical. You'll notice the esophagus, no digestion. We're just moving it down. That's all we're doing. It's just a tube for gravity to work on. Okay. And then the liver, or sorry, not the liver, in the stomach. We've got mechanical digestion as well. So we saw that there's some muscles in the stomach, and we're moving and churning and squeezing them around. Your tummy's grumbling. You can feel that moving around. And so that's mechanical digestion as well. Think like a washing machine. That's what's going on in your stomach. There's also more chemical digestion of proteins and fats. Stomach acid breaks down proteins. You're taking the lime juice, you're squeezing it on a steak, you're creating ceviche. Fish, you're creating ceviche. Okay, so you are denaturing proteins with the acid, you're mixing it all up, and sometimes you are absorbing lipid soluble substances such as alcohol and aspirin. Okay, lipid soluble is the key here. So things that are soluble in lipids kind of get absorbed mostly a little bit in the stomach. Okay. Right from there, you're moving it through the pylorus and into the small intestine. Your mechanical digestion is segmentation and the peristalsis movements through the small intestine. You're chemically digesting it through other chemicals that are being pumped in via say the gallbladder or the pancreas is shooting some stuff into your small intestine. Pancreatic amylase is getting pumped into your duodenum, so you're breaking down starches even more from that. And then you're starting to absorb all of those because they've broken down all the way, and you are absorbing those into your small intestine. Okay. So once you break down all of those things, you end up with peptides, amino acids, glucose, fructose, fat, water, minerals, and vitamins. So you've broken down all of that stuff into building blocks, and you're starting to pull those bricks into your body to use them yourself. Okay. From there, we move to the large intestine, and mechanical digestion includes segmental mixing and propulsion. So a little bit more of the segmental mixing. There's no chemical digestion except for bacteria. Good gut health, right? But you're mostly absorbing ions, waters, minerals, vitamins, organic molecules. So think really small in the large intestine. I know it's counterintuitive, but like really, I cannot stress enough. Small intestine, large intestine is diameter only. So everything else is reversed. Okay. All right. Now, absorption of water. So you're secreting a lot of water throughout this process, right? So, like, say you eat food, and that might be 200 or 2,000 milliliters of water. Okay, so like a juicy steak or a juicy hamburger. Okay, there's water in that, right? That's why it's juicy, right? You're gonna secrete some saliva, so you're creating some water right here, and then you're ending up with about 5,000 milliliters of goo in your stomach. And then you're going to secrete stomach acid, right? And then you have to neutralize that stomach acid, and you're going to secrete bile, pancreatic juices. Why does it keep saying juices? I mean, use different enzymes. It's a good thing. And then there's also other intestinal secretions. So by then you've got a big belly, right? Like you're full, right? And you've got 9,000 milliliters worth of water. So you have to reabsorb most of that. And that does happen in the small intestine. And then you're going to move it all the way through that process, and you're going to start secreting a little bit of mucus, but then you're going to reabsorb whatever's left. So that's taking that juicy fecal matter and it's condensing it. Okay, so you're pulling out that last bit before it becomes solid. So in the small intestine, food is pretty juicy. All right, it's all liquid going through there, and it doesn't get until you get to that last little bit where it really starts to kind of um, like thicken up, I guess, and then you're able to excrete it. Okay, so it's all liquid, it's all being absorbed, and then you are going to concentrate it and then excrete it. Okay. All right, so this is, let's see, can we do this wrong? Yeah, hang on. Hold please. Got 15 minutes and a couple slides. Okay. Where are we at? Slide should we have here? Okay, so, okay. I think we can do this. So, starch, glycogen, this gets broken down by salivary amylase. Okay, so saliva amylase. Amy is starch, lase is cut. So cut the starch with saliva. Okay, that will break the starch into disaccharides, so maltose, sucrose, lactose, and those end up as either 2-glucose, sucrose gets broken down by this enzyme, sucrase. ACE is an enzyme, right? So maltase, sucrase, lactase. And you break those down into monosaccharides, okay? So disaccharide versus monosaccharide. I don't know how much you guys have learned about this. I would hope so, maybe like biology or something like that. But let's see if I can find a picture. Yeah, so from here, so this is a sugar. Like say this is a glucose. What is a glucose? Cool, good guys. A disaccharide is 2 glucose stuck together, and then you're gonna cut that across. Okay, so you're gonna have one, and you're gonna absorb that. Okay. So glucose, fructose, and then lactase is glucose and galactose. Okay, so 2 glucoses, 2 sugars, 2 sugars. Okay. Salivary amylase. There's also pancreatic amylase. So we talk about that. Maybe not. So starches and glycogen are broken down into glucose by amylase and maltase. And they're broken down by all these enzymes. Okay, cool. All right, protein. So protein digestion begins in the stomach. It starts, I mean, that's kind of a lie. It starts in the mouth, right? Because we're chewing, right? So we're breaking down that protein a little bit, and then we're digesting it in the stomach by hydrochloric acid and the enzyme pepsin. So pepsin is an enzyme that breaks down peptides, right? So protein, peptides, pepsin, all makes sense. Okay, and then protein digesting enzymes are secreted from the pancreas into the small intestine. And the where are we at? Sorry, I'm trying to get my bearing. The small intestine is where protein digestion happens, and then final digestion occurs here. And then we're going to reabsorb it into the small intestine. From there, it's going to get shunted into the portal vein and into the liver, where the liver will regulate the distribution of amino acids to the rest of the body. Okay. The liver also will package up fats and carbs and not carbs, but it'll package up fats and cholesterols, right? Too. So the liver kind of acts as almost like an Amazon Prime. Okay, so the distributors send their packages to the liver, and that sends it throughout the body. Okay, and then the amino acids enter the bloodstream, travel to the liver, get packaged, and then distributed. Okay, and then we're going to lose a little bit of protein in the feces. So protein's the hardest one to digest, so it's not going to be 100% accurate. Starch is really easy to digest. All right, so protein, we get pepsin, we have large polypeptides, and then those get broken down into short peptides and amino acids. And the amino acids are what are absorbed. Okay, so we're not bringing in whole peptides, we're going to break them down into amino acids, and then those get absorbed into the body. Okay. Lipids, this one's fun. All right, so they are absorbed through epithelial cells, like at that brush border, right here. You can't really read this, but let me give you a Cliff Notes version. So if we have lipids are emulsified by the bile, so the bile, think if you were to take um, uh, like oil, right, and an egg white, and you put a blender in it, and it makes mayonnaise. That's called emulsification. So you're creating a homogeneous emulsified solution with the lipids. Those are going to get subdivided into these little tiny circles. Okay, and those circles are fatty acids and uh, we'll just say triglycerides, right? So triglyceride, if we remember what it looks like, it's three fatty acid chains and a uh, backbone. What's the backbone? A glycerol backbone. Glycerol backbone. Yes. Sorry. Triglycerol. Okay. Yeah. So glycerol backbone and a three fatty acid chain. Okay. So those are going to create what are called micelles. So we'll take these are all hydrophobic, right? And we're in a liquid substance, which is mostly water. Remember that 9,000 milliliters of water. With those hydrophobic things, those will create micelles. Micelles are the fat sticking together because they don't want to mix with the water. So think if you were to take olive oil and just kind of like blast it into a cup of water, you see those little bubbles that are lipids. Those are micelles. Okay, so those individual micelles will kind of fall into, let's say, in between these little microvilli on the brush border, and then those will get pinched off, and then we create these little vesicles that go into the Golgi, right? And then those get packaged up into um, cholesterol. With cholesterol, they are turned into um, HDLs, VLDLs, and LDLs. Okay, and then those move out of the cell and into the lymphatic capillary, and then into the portal vein. Okay, and then they get repackaged by the liver and distributed. Cool, cool. Homeostatic imbalances of the digestive tract. These are things that could go wrong. Really, we'll go really quick. Dental caries, that is a cavity. Gingivitis, gum disease. Halitosis, bad breath. Mumps, virus. Hiatal hernia is a hernia. So we're taking that, if this is the intestine, we've got a hole, we're sticking it up through there, and we're pinching it off. You can't move it through the digestive tract, it's bad. Acid reflux and GERD, so that is the gastroesophageal sphincter is not functioning, and we're pushing acid back in the esophagus, which is bad, which will cause an ulcer, which is acid breaking down the lining. Okay. Ascites, that's liver failure and buildup of water in your abdomen. Pancreatitis is a inflammatory pancreas. Hepatitis is an inflammatory liver, and that can be caused by viruses or drinking. Cirrhosis is a end stage fibrosis of the liver, and it's like basically ulcers in the liver. That's also bad. You will not survive that. Gallstones we talked about. Jaundice is the liver not breaking down bilirubin, and it turns your skin yellow, which is bad. Sometimes, if you're an adult, it's bad. If you're a little tiny baby, it's normal. Enteritis is inflammation of the enteric region, so like your stomach, basically. Colitis, inflammation of your stomach, of your colon. Sorry, this is small intestine, this is large intestine. Hemorrhoids, those are bad. That is vascular vesicles that can be caused usually in the rectum. So internal hemorrhoids or external hemorrhoids. Those can be caused by portal vein pressure or basically vascular pressure. Okay. Diarrhea, loose stool, constipation, loose stool, diverticulitis. Those are little outpouchings within the colon. So those little villi looking things, they get big, they kind of stick out, and that's bad. And they get inflamed, and that's bad. Or appendicitis, which is bad, but not as bad as you think it is. That's all I got. Cool. For lab, we're going to do no lab today because I'm going to do a review session for the other group, and you guys are more than welcome to use that time to study or not study, whatever. I don't care. So yeah, so that's the digestive system. Hopefully after the test next week, we're going to kind of move through the lab portion for this, and then we'll start mixing because we've got metabolism for lecture next week. So we'll be able to catch up a little bit, and then lecture and lab should be like pretty close to each other from then on out. Okay. But for now, it is not tonight. So we do office hours for the class. So I gave you guys an office hour. You ask questions. So any questions? That's all I got for you.